I mentioned, my name is Jill Kagan, and I am with ARCH. ARCH also houses the Lifespan Respite Training and Technical Assistance Center, which is funded by the U.S. Administration on Aging. And we are very honored to be partnering in this training and TA effort with our colleagues at the Family Caregiver Alliance, which is based in San Francisco. This is the third in a series of topical webinars that ARCH will be offering under its AOA grant in an effort to promote statewide lifespan respite systems, as well as we'll also be doing that to help expand respite capacity and accessibility in local communities. Lifespan Respite is all about collaboration, and so our webinar is very timely today. We're hoping that our efforts will be to help states and others interested in respite identify new partners and new ways of providing respite. Before we do get started, I do want to reiterate a few points that Emily made. Because of the large number of webinar participants, your phones have been muted and will remain muted for the entire presentation. Also, as Emily said, if you have questions or comments, you can pull up your control panel and type in your questions in the question box on the control panel, as Emily indicated. If your question is related directly to whether or not you can hear or see the webinar, Emily will get back to you via that question box as soon as she can. Feel free to type in your questions during the presentations themselves. You know, if something comes up that you think of that you want to make sure you ask a presenter, you can type that question into the question box. And if you want to direct it toward a particular presenter, please incorporate the name of the presenter into the question so Emily can direct it. At the end of when all the presentations are over, Emily will read those questions and have the presenters respond. If we don't get to your question while we are still live, and we'll try to get through as many as we can, we will respond to your question via email following the webinar in the next couple of days. In addition, if you're not able to stay for the whole program, or if you have some colleagues who couldn't make it today, the webinar will be archived at the ARCH website within a few days. You will be receiving a follow-up email that will tell you how to connect to the archived program and the background materials that you should have received by email today. Before we get started, I just want to introduce our presenters. First, we have Barbara Snyder, who is Director of Corporate and Foundation Relations at Easter Seals, Delaware, and Maryland's Eastern Shore. She's also Director of the Delaware Lifespan Respite Network. Barbara Schwartz with the Illinois Department on Aging is the Project Supervisor for the Lifespan Respite Grant, as well as the Caregiver, Kinship, and Intergenerational Programs for the state of Illinois. And finally, we're very honored to have Joseph Lugo, who's an Aging Services Program Specialist with the Administration on Aging, U.S. Department of Health and Human Services. Just for a little background, I wanted to talk a little bit about what we mean by collaboration. In the health field, in social services, and even when we're talking about delivery of services to family caregivers, collaboration has become an essential component of program development, implementation, and even evaluation at the local, state, and federal levels. In fact, some issues that we're working on now have become so complex, and the systems we're trying to affect have become so fragmented, it's becoming increasingly difficult to achieve any level of success on our own. We must turn to our experts for knowledge and the experience that we don't have. And I know all of you are very familiar with how limited resources are these days, that it's become a situation such that we have to share what we have, and then we must, in turn, look to our community partners for resources that we need. There's hardly a funding opportunity now, whether it's governmental or private, that does not require some level of collaboration at the community level or the regional level or even the state level before you can even complete the funding application. As you can see from this slide, not all the shared efforts begin at the point of collaboration. Organizations have a variety of options for working with others with common interests, beginning with informal networking, which is the exchange of information, all the way up to collaboration, which is not only about exchanging the information, but also about altering activities, sharing resources, and enhancing the capacity of another organization for mutual benefit and to achieve a common purpose. Collaboration, cooperation, and coordination are all themes entrenched in the Lifespan Respite Care Program. Each of the primary stakeholders, and that involves the state agencies, the State Respite Coalitions, and the Aging and the Disability Resource Center, are built on a foundation of their own internal collaborative relationships. In a successful Lifespan Respite program, these stakeholders with others ultimately come together to collaborate and build a multi-sector accessible respite system. These themes are embedded in the very definition of Lifespan Respite, which is a coordinated system of community-based respite for family caregivers of children or adults regardless of special need. You can't really talk about building systems without talking about coordination and collaboration. Lifespan Respite programs also require, and this is legislatively, that the state lead entity work in collaboration with the State Respite Coalition or organization. And finally, the Aging and Disability Resource Center, the ADRC, which we'll call it from this point on, is a model for building collaborative partnerships in and of itself. So we have a lot to learn from the Aging and Disability Resource Centers and how they're built on partnerships. And they also, by law, are required to be involved in the Lifespan Respite program in some capacity. Today, our presenters are going to address collaboration first from that perspective of building a state coalition, which then grew into a Lifespan Respite system. And Barbara Snyder from Delaware is going to be talking about this. Then we'll move on to Barbara Schwartz from Illinois, who will talk about the successful collaboration they've already achieved among state agencies that must first occur before successful Lifespan Respite implementation. And finally, Joseph Lugo from AOA will share the lessons from the ADRCs, which, as I said earlier, rely on those community partnerships they build to ensure that all individuals with disabilities and chronic conditions have that single door or no wrong door for entry into the long-term care system. With that, I turn the floor over to our first speaker, Barbara Snyder. Thank you, Barbara. You can go ahead.
All right. Thank you for having me on the panel and for representing the Delaware Caregiver Support Coalition. The group started as a result of a report that was published in 2003 by the Center for Disability Studies of the University of Delaware. They had convened a group of caregivers to look at the state of respite in Delaware. And as a result of that report, essentially said that we didn't know enough about what was happening or what the real needs were. Fortunately, the CEO of Easter Seals in Delaware decided that that report shouldn't stay on a shelf, but that we should do something about it. And she convened a large array of disability-oriented organizations and consumers to meet and begin the task of better understanding respite. I should say, too, that perhaps Delaware has an advantage because we are a small state, and bringing people together is fairly easy. We're only 3 counties. And also in our state, we already had some collaborative groups meeting that really provided the foundation for our coalition. That group includes a broad array of nonprofit providers, consumers, state agencies to begin looking at the issue of respite. The group also developed a charter and had clear goals about the direction that they wanted to head. And first of all, as I've indicated, we needed to understand the current state of respite in Delaware, the gaps, the needs, the desires of consumers to be able to support their needs. Then we moved on once we did a survey of both caregivers and of providers and having a better understanding, trying to design a system to address those issues. And finally, our third goal was to develop a funding strategy. Fortunately for us, from the very beginning, because this whole thing started at an academic institution, we were able to have a trail of written reports. So each time along the way, as we addressed each of those goals, we had a report. And that report served as a way to document what we had done and to help us move forward. We also had a symposium. All of this was taking place over a 6-year period. And we have proceedings from the symposium. And in the final report was a 3-year plan and a budget that we were able to take the funders, and ultimately we were able to get 3 large grants from local foundations. Next slide, Jill. Next slide, Jill. Our membership is not formal. We've taken the approach of if an organization or individual is interested in respite, they can be part of our group. We are not a 501c3 organization. As the group moved forward in terms of its structure, it decided to choose Easter Seals as the lead agency to be the fiscal agent. And we continue to build membership through reaching out and including others. Currently, our structure, it includes an advisory committee that has at least 15 people on it. We don't have bylaws. We have a guideline of what we want our advisory committee to consist of. So we want at least 15 people that represent fairly equally consumers, providers, and state agency representatives. And we also have been developing subcommittees as we have begun to detail work that needs to take place. And those include financial assistance, outreach, providers, and sustainability. Our major activities in terms of supporting families are really 2. One is helping families find care, and the other is to fund care. So we are providing information and referrals through a web-based database that people can access on our website, and you see the web address there. But we also have a toll-free number that individuals can call so that they can speak to somebody and get help in finding care. And secondly, we do help families fund care, and we do that through a voucher process. Families complete an application either online or using a hard copy. It's reviewed by a committee, and they can be awarded up to $500 a year per care recipient. We also are actively involved in public awareness and outreach to caregivers through the agency, through part of our coalition, and to the general public as well, raising awareness of the need for respite for caregivers. And in the future, we're hoping to move into the issue which has been identified, and that is recruiting and training providers. Next slide, Jill. In terms of our current status, we are in the 2nd of 3 years of funding, and as I mentioned, we got it from foundation, so it's totally private. We've been working closely with state agencies to keep them informed. They are part of our coalition, but like many states, our state budget is bleak, and we're a bit pessimistic about how much public money we'll be able to involve in our process, but we are working on keeping state agencies informed. And we continue to try to expand the scope of people who are involved in our coalition. And this year we were fortunate to have a respite coalition with Jill as our keynote. That happened in March. We had over 80 people participating, and we're really pleased that this event again raised a high level of awareness and involved a significant number of new agencies and individuals, particularly on the adult and aging side. Our coalition from the beginning was very heavily child-focused. So particularly because we were focusing on preparation for federal application for respite dollars, there was a large contingent of agencies that address aging issues. And also as a result of that summit, we have become more closely engaged with our state Office on Aging and are pleased that beginning in the fall, Easter Seals will have located on one of its sites a Caregiver Resource Center, which is the backbone of our state ADRC. And we're pleased because that will now co-locate ADRC type activities with our respite program and provide a natural venue for ongoing discussions and collaboration. And finally, I just wanted to say that in terms of how we view keeping people involved and engaged in our collaboration, we do try to be inclusive. As I said before, any individual or agency that is interested in this issue, we add to our list. We try to keep them involved. We try to keep people informed, and we do that in a variety of ways. We do have quarterly advisory committee meetings. Our subcommittees are meeting fairly regularly. We use emails. We've just started using Constant Contact and have published our first newsletter to celebrate the first anniversary of our providing services. And we continue to make sure that we're documenting through reports and proceedings so that we continue to have materials that we can point people to understand what we're doing. And finally, we really do feel that being goal-oriented is important, understanding what the next step is, what you're trying to accomplish. It's much easier to recruit people to be involved if they understand what you're trying to do, where you're headed. And in that way, we keep the momentum going because we can see successes that we have. So thank you for letting me share about the Delaware Caregiver Support Coalition.
Thank you very much, Barbara. And now we'll turn it over to Barbara Schwartz from Illinois.
Thank you, Jill, and thank you for having me on the panel to represent the Illinois Department on Aging and our partner in crime, the Illinois Respite Coalition. I, as Jill mentioned earlier, supervise the Lifespan Respite Grant for IDOA, as well as the Caregiver Program, the Intergenerational Program, and Relatives as Parents Program. And through the Relatives as Parents Program, the Department on Aging became involved with the Illinois Respite Coalition. And then through the Relatives as Parents Program, the Illinois Department on Aging also became very closely involved with other state agencies that work with children, such as Department of Human Services, Department of Children and Family Services, Health Care and Family Services, the Illinois State Board of Education, and Department of Corrections. IDOA also collaborates with our 13 area agencies on aging for relatives as parents through the National Family Caregiver Support Program. And it was through this that we were able to link the Illinois Respite Coalition to the area agencies on aging and expand the network that way. And through the Illinois Respite Coalition, we became involved with the ARCH network, and that led to the Lifespan Respite Grant application, which involved IDOA. The Illinois Respite Coalition was actually insistent that the Illinois Department on Aging be the one to apply for the respite grant, and we did so with the collaboration and support of two of the major state agencies, which is the Department of Human Services and the Department of Children and Family Services. So I think we can go down to the next slide. The components of our Illinois Lifespan Respite Grant is that through the Illinois Respite Coalition, they are providing the training and education and outreach for other providers and agencies. They are doing that on a statewide basis and working closely with them to see what training opportunities are being provided as well as what training opportunities they can provide. They also work with other agencies and faith-based organizations to do so. The collaboration in the task force, part of our grant stipulated that we would create a task force, a respite task force. And doing so, we brought basically the two largest state agencies that provide respite services to the table. And that was the Department of Children and Family Services as well as the Department of Human Services. Public Health is also at the table, as are the ADRCs and the Area Agencies on Aging. But what we found from the beginning was that the state agencies had little contact with each other with regards to respite, and there was little sharing of information even within the agencies and the different divisions and bureaus concerning their respite programs. So for instance, the Department of Human Services provides respite for their specific populations through the Division of Rehabilitation Services. They have 5 types of service providers, 3 waiver programs, for instance, brain injury, HIV, AIDS, and DD. They have the Division of Mental Health, and they have the Division of Developmental Disabilities, which contract with about 60 agencies statewide. And then they also have the Division of Community Health and Prevention. So within DHS, you've got those 4 divisions that are offering respite programs and services. Then with the Department of Children and Family Services, again, the types of respite programs vary. They have their post-adoption and guardianship division. They have adoption preservation. They have their local area networks, intact families, and they have their POS agencies, which are purchase of service agencies, private agencies. They also have foster care. Investigations provide some respite opportunities, and they have specialized foster care, which under specialized foster care has the DD population, medically fragile children, and children with mental health issues. And respite services are provided to those populations through all of those programs. So bringing them to the table on this task force has been extremely interesting and very helpful because it's allowed us to begin talking with them. It's also provided the IRC an opportunity to become aware of and participate in many other sub-activities and committees that they should be involved with but weren't necessarily aware of. And right now, I am in the process of kind of wrapping my arms around all of these different respite programs and trying to define the funding level, the eligibility level, and the types of respite that are provided. By doing so, we're hoping to identify the gaps in service, which we are, and also, as Barbara mentioned earlier, with every state probably in the same financial situation, as programs are being cut or eliminated, we need to know who's going to pick up the slack and who can pick up the slack. And so I think that this is fortuitous that we've created this task force at this very severe budget time. So again, accessibility to information and resources. The IRC is expanding their website, and we are also linking to the agency's websites. The IRC will be linking to those websites, as will our agency. We are creating a toll-free number. We will either establish our own or partner with another. We're in the process of evaluating that. Outreach and development of resources. The IRC has developed a training manual. Right now, they are in the process of developing a brochure so that we can start to provide that in outreach activities. Next slide. So how extensive is collaboration among state agencies? As I mentioned earlier, prior to this, it really was not extensive at all. There was little collaboration. Everybody was just kind of involved in their own programs. It was very concentrated within each agency. Levels of success, I think, you know, how do you measure the success? I think part of that is the maximum utilization of resources, and especially now with these budget cuts and programs on the chopping block, we have to really be careful with that and maximize those resources as much as possible. We found, of course, I mentioned earlier that all these programs kind of operate on an island, and there's little collaboration and coordination between the agencies and even within the agencies. So the task force has and will open a dialogue between those agencies and within those agencies and expose the Illinois Respite Coalition and the area agencies on aging and the ADRCs to these agencies. And quite frankly, many of these agencies weren't aware of those organizations that I mentioned. And the role of the State Respite Coalitions and ADRCs, again, we are trying to tie them all in together. The IRC will eventually take a lead role in the coordination of information and resources and training. They are already starting to do that. And, you know, it is our goal that they are the go-to organization in Illinois for respite referrals, for respite resources, and for questions about respite. And that should do it. Examples of innovative collaborations in Illinois Lifespan Respite. We have partnered with crisis nurseries throughout the state, and this is with the Relatives as Parents program, to provide respite to relatives raising children. There are 6 crisis nurseries in Illinois, and they serve children from the ages of birth to 5 or birth to 6, dependent upon the nursery. And we've provided state funding to those through my program to those crisis nurseries to offer slots for relatives should they need the services of that nursery. The provision of emergency respite is written into our Lifespan Respite grant. I noticed in Barbara's presentation that Delaware also offers something similar, and we are in the process now of developing the eligibility and criteria and payment structure for emergency respite for those families across the lifespan who could contact the Illinois Respite Coalition in the need when they have a need for emergency respite. And utilizing support group resources, again, through the Relatives as Parents program, our support groups have child care during the support group meetings. And the beauty of this is that the children, many of whom have special needs, are very familiar with the child care provider. And the relative is very comfortable with that child care provider. So what the support group has done is taken some of our funding and is providing that child care opportunity for those relatives on a Saturday, above and beyond the support group meeting. And so they can make a reservation and take the child there for an hour or 5 hours or 6 hours. And it's worked out beautifully and provided another source of respite for these relatives. And I imagine that that could also perhaps be expanded to support groups that are dealing with other types of disabilities too. And I think that takes care of my portion of the presentation.
Thank you so much, Barbara. I appreciate that very much. We're now going to hear from Joseph Lugo. And I am, let me see, handing him control of his mouse. And you should have that now.
Okay. Can you hear me okay?
Yes. Mm-hmm.
And to advance the next slide.
Are you able to control it? Yeah, I see you can control it.
Yeah, I just need to, how do I advance the next slide, that's all.
It's in the left-hand corner, right under the AOA logo. If you toggle, there you go.
There it is, all right. Okay. Well, hello everyone. Thank you for investing the time to be part of this webinar. I only have one data slide, so I thought, you know what, I'll just put it up front so we can get it out of the way. But one of the things we wanted to try to at least first look at in terms of the ADRC world is what are some of the expectations that individuals have in terms of the people we're trying to reach and trying to serve. So one of our ADRC states asked 4 key questions to the people they were trying to reach. Do you know what services are available and how to apply? Do you is information about those services simple and clear? Is applying for those simple services simple? And is your plan of care based on choices that you made? Is it consumer-directed or participant-directed? And one of the things that was unique about this is that we really looked, or the state looked across the lifespan, not just older adults, so really looking at different populations and disability groups. And what they found was that about 1 out of every 4 individuals that they were reaching or touching was satisfied or felt empowered by the services they were receiving. And one of the challenges that we really pushed to our ADRCs up front is how many organizations do you know, or any businesses, stay open by only satisfying 1 out of every 4 individuals. And typically, outside the DMV, we can't think of an organization. So, but this was something we kind of addressed up front. We kind of knew what the challenge was waiting for. This is our mission. That's part of the ADRC. Really has not changed a lot since 2003. One of the a great book that I came across on organizational change had a quote, and it said that people don't resist change, they resist being changed. And it really talked about that you can't force someone to adopt a vision, regardless of how compelling it might be, unless that they really buy into it or can take ownership over it. And I think one of the things that's helped with this initiative is that states have kind of taken this and adopted it to what's worked best for them. I think in terms of major milestones, in 2006 with reauthorization of the Older Americans Act, really helped embed a lot of the ADRC principles into the Act. And most recently with the Affordable Care Act, a number of places were talking about this ADRC initiative, but specifically there's dollars allocated over the next 5 years, so $10 million each year for the next 5 years to support ADRC efforts. So that kind of really helped validate that this partnership model makes sense and has value. In terms of some of the key, we're going to hit on these a lot, but some of the key kind of principles that we try to stress in the vision, one is visible and trusted place that we're trying, and it's places. Rarely this is one organization, whether it's face-to-face, whether it's over the phone or via the web. Really an opportunity to get the full range of long-term support options. This isn't just an access point where you're trying to get to public benefits. Hopefully you're getting a sense of private resources as well. And then finally, a coordinated point of entry, a no wrong door system. We're going to talk about the importance of terminology later on, but in terms of now, I'm flexible with either one. One of the things that I think would be helpful in terms of respite providers or respite resources is when you think about the ADRC, sometimes we encourage people, kind of look behind the curtain in terms of this term ADRC, because there are functional components that each ADRC should be performing or should be striving to perform. And I wanted to walk with you some of these key functions. So when you're talking to an ADRC partner or a state lead, instead of just saying, how's your ADRC effort, you can really go right to these core functions and say, okay, in this particular area, how could I work with you or partner with you? The first is really this thing called awareness information, kind of a similar image to kind of show that as a storefront window or a front door to kind of health and long-term care. This is where our states and local areas are really trying to create that awareness, that visible and trusted place. One common denominator that we see states moving to are these statewide databases. Much of our network was paper-based pre-ADRC. We still have a lot of places where that's still fine, but we're seeing a lot of movement to the web-based databases for public and private resources. Kind of the next functional component to talk with states is this thing called options counseling. It's really a chance where it's not information referral, it's not case management, it's really recognizing that there's a gap in between there. There are individuals who need more than just a list of providers. They don't want to kind of be case managed, but they need someone to help gather, filter, and customize information for them. It's really kind of decision support, and we call this options counseling. Literally right now, states have submitted applications to AOA and CMS for an effort to try to help standardize this process, kind of develop some operating procedures. So over the next 12 months, we'll be working with states on developing what would state standards look like for options counseling? Because there's still some key areas in terms of training, how is this triggered, that need to kind of be solidified. But one of the things we need to look at is if somebody's going through an options counseling session, what respite resources could that individual turn to? Very similar to kind of AIR certification, making sure that we're ingrained in that aspect. It's just kind of the next step in terms of options counseling. And we use kind of a map to help symbolize that. The third kind of core function that each ADRC should be working on and developing is this access component. We have kind of this little skeleton key that we use. But can we make the intake forms a little more consistent? Can we try to coordinate functional and financial eligibility a little bit? One of the trends that we're seeing now in terms of access is really reaching out and developing relationships between aging disability networks with hospitals, physician practices, nursing homes, and this whole area of care transitions, helping individuals transition from these settings and then trying to put services in place. So obviously one would be respite. But it's clearly a very hot topic right now in terms of buzz. And some of the models that I'm going to talk about later kind of touch upon what we're starting to see in terms of developing partnerships. One of the things that we do try to stress, because when you start mentioning, especially when you use the term single point of entry, some providers or organizations start to think, well, is that realistic? To have, as one organization can carry out even those three functions that I listed in the previous screen. And one of the things we try to stress is that from an outside view, from the consumer view, you try to create this one-stop access. But behind the scenes, what you're seeing really is it's multiple organizations working together to try to pull this off. And some states and organizations will use like warm transfers. We have seen some infrastructure building that's had to be done in terms of their telephone systems. Kind of voice over, kind of IP, using the internet to help transfer. But sometimes it's very simple stuff in terms of just co-locating staff, maybe for 1 or 2 days a week. It doesn't have to be high-tech at all. But from the consumer perspective, it looks like, oh, this is seamless. I'm dealing with one network. But really behind the scenes, it does take a little more work, but when you're able to get some of these partnerships in place, it creates, I hate to use the word illusion, but it creates the appearance that it is one organization that you're working with. And also, it helps the organizations keep their own identity. A lot of times, whether it's a AAA or an ADRC, they have a long history in the community, and they're kind of afraid of, do I have to give that up to be part of this partnership opportunity? And in this kind of model, we're saying, no, you really don't, if you can do some of these things behind the scenes. All right, you should be looking at a blank screen with blue on top and white on bottom. Everything is working okay. One of the things I wanted to try to share is I do get a chance to kind of visit different states and get a chance to get feedback on developing partnerships and getting feedback on this ADRC initiative. And people ask, well, what kind of reaction are you getting? What kind of feedback? So I thought, well, I was kind of gathering my thoughts about this, and I thought, well, could I take it a little bit further and say, are there maybe, are there kind of commonalities? Are there groups that I would kind of put some of these individuals in? And I kind of started to see some patterns. And then I thought, well, can I take it a little bit further? And I thought, well, is there maybe a movie that would maybe kind of help symbolize some of these groups? And I thought, well, you know what, let's just give it a chance. Let's see if we can identify maybe a particular movie that really captured the spirit of some of these groups that I was working with. So the first kind of group that I kind of helped categorize was this group called the Jerry Maguire group. And I put them together because some of the things that they were kind of saying. They really thought, this partnership fits exactly with our vision. It's a really good fit. You're a partner that we've been trying to reach out to. We wanted to do this. And immediately from the start, it's like, how can we work together? Let's start to do this right away. And if they had a battle cry, it would be, you had me at hello. Right from the beginning, this is exactly what I wanted to do. They still are saying, show me the money. But definitely, right from the start, it's a great exchange. But as you can imagine, this isn't the only kind of group and feedback that we have received. The second kind of group, I would say, I put together as I call kind of our Braveheart group. And sometimes you can just kind of see these individuals or organizations putting face paint under their eyes, and you know this partnership is going to take a little work. And some of the kind of comments that you see is, or hear, is why is this group wanting to partner with us? What's in it for them? What's in it for us? Is this possible competition for us in the future? Is this organization or organizations like it, could it be competing for some of the duties or taking over some of the duties that we perform? And if they had a battle cry, I think it would be, well, you could take our contracts, but you'll never take our freedom. So I've had many of these moments, a lot of rewarding aspects of being involved with this job, but seeing individuals who start in this group and kind of seeing them transition into maybe the Jerry Maguire group, it's probably one of the more rewarding aspects, and really seeing them become champions even if they start in this place. Now, I did bring one other group, one last group, and I call it kind of my not Jerry Maguire, it's my Forrest Gump group. And it's maybe different than what you think. There's a scene, if you haven't seen the movie Forrest Gump, where he starts running. He runs for 3 years. He runs 2 months, 14 days, and 16 hours. He doesn't tell anybody why he's running, but this group of individuals start following to try to figure this out. Well, after this amount of time, he stops on the road. He turns around and he says, you know what, I'm pretty tired. I think I'm going to go home now. Well, the Aging Network has been running for about 45 years. The Disability Network nearly as long. And some of the feedback we get is, you know what, we're working with a limited budget. We're asked to do more and more without additional money. We just don't have the time, energy, or staff to kind of develop any of these partnerships. And it's a very real response. It's a very genuine response. And I think one of the things we try to stress is that you really have to recognize where your partners are if you hope to move them to a new place where you want them to be. And one of the things we try to stress over and over is that this isn't about replacing organizations or what you do, but it's building a better, more coordinated network. In terms of actual number of partnerships, what do they look like? Just to give you a quick landscape, right now, ADRC's 54 states and territories have received a grant to develop ADRCs. There's over 280 program sites across the country. About 190 million individuals live in an ADRC service area. 13 or more states have statewide coverage. And one of the things that seems to be common across these states is that the partnerships really become formalized, whether it's at the state level or at the pilot level. On average at the state, it's about 9 formal partnerships, and at the pilot level, it's almost 8 number of partners. And typically, maybe sometimes when we describe partnerships, it's simply just putting my logo or my name on your brochure. We've really tried to move away from that with the ADRC effort and really try to formalize them, whether it's a memorandum of agreement or understanding, whether it's a co-location of staff, formal referral protocols, cross-training of staff, really critical. Probably Massachusetts is one of our leading states in terms of cross-training. In terms of co-location staff, probably Florida is a wonderful example. I'll provide a website at the end if you want to kind of look up specific examples. The joint marketing outreach, which is not new to a lot of states. The client service collaborations, share and our resources. One of the things with aging disability, we have different strengths, and it's one of the things we have to kind of recognize. But traditionally from the Aging Network, it's a very formalized, very sophisticated INA system. Many providers in the Disability Network aren't kind of used to that or have that. So being able to work together to be able to kind of, share those resources, sharing the client data. What does a good partner look like? One of the exercises that we kind of work with our partners at our national conferences we have, well, I'll just give you a specific example. We were at a recent National Council for Independent Living conference, where this is a conference for Centers for Independent Living from across the country. And we asked them, what does a good partner look like? And we kind of got their top 10 list, and I'll just read those to you real quick. It's on their web, but I'll just read it real quick. The number 10, you could say, or so, is they bring energy to the partnership. They bring human resources. They have a similar philosophy as our organization. They bring balance to their organization. there's a reciprocity in place. They're looking for a partner that can maybe help increase public exposure. Looking for partnerships that have a different perspective or diverse backgrounds. Looking for a partner really to help their expertise. And the number one characteristic they were looking for that a good partner has was an organization that brings discretionary dollars, which seems to bring a laugh to the audience. But anytime we do ask this question and do this exercise with the audience, then the very next question we ask is, well, what do you look like? Are you an organization that you would want to partner with? And it can be a very difficult question to kind of address. And it's not only you, because you could be at a point where you are ready. You're ready to make this change from really developing these formal partnerships. But unfortunately, you're not the only individual in your organization. You have to kind of think, well, how prepared are we as an organization in terms of your board, your staff? You will get pushback in terms of, is this part of our core mission? Is there kind of a mission drift going on in terms of what we're trying to do? I guess there's some controversy in the next statement, but some people have argued that no partnership is equal. It rarely is it going to be an equal partnership, benefits and consequences for either one. So are you willing to live with a partnership that might not be completely equal and compromise? And then one of the things we kind of do is just kind of help organizations ask, well, where do you start? Do an inventory of where you are, do a self-examination, in sense of defining who your organization is, at least your own perspective, and then maybe do an external evaluation of how do organizations see this. But kind of a walkthrough in terms of what are some questions we need to be asking if we're serious about developing these partnerships. I think another thing to kind of think about is when you're working with, regardless of what state you might be in, the term ADRC is simply to kind of help label the initiative. But when you go into specific states, how they define it is going to look much different. So if I'm in Maryland, it's going to be Maryland Access Point. If I'm in Louisiana, it's going to be Louisiana Answers. It's going to be a little bit different. It's kind of really building off the flexibility of the Old Americans Act, giving the states a chance to customize it to their own state. So it's one thing to recognize. I wanted to kind of maybe talk about some of the lessons learned, because I don't want this to come across as, oh, we've done everything right. I think we've done enough wrong that I think some of the lessons we've learned from that I think might be valuable. One of the errors we made right up front, I think when we were launching this initiative, was the grantee was required to have to meet certain specific requirements within 12 months. And then after that 12 months, then they would have to then, do other activities. Well, many of our grantees, and if you looked at the guidance we were giving them, they were just following the guidance that we were provided, was that they would bring in the partners to do the activities in that 12 months, and then when they went to the next activities, then they would start to bring in new partners. And we heard consistently, many of the disability partners would come to us and say, why are you bringing us up so late in the game? So much has already been developed. We feel almost like, not second class, but it would have been a lot easier if you would have just pulled us from the beginning. And it's not only disability, it's the IT partners, it's Medicaid. So one of the things we learned is really try to see your end outcome first. Try to bring in all those partners right in the beginning. Even if they're not having to be used right away, it'll really help the buy-in later on. In terms of helping the buy-in, another lesson we learned is really kind of look at where do you have your similarities, whether it's mission, values, or goals. Where do they align? Sometimes having a common enemy is another place too. What specific barriers? When you look at independence, when you look at transportation or respite or voting, some of these issues cut across the lifespan. So can you work on a specific project to help develop this? Next, terminology. So many situations that we come across, just the language that we use is much different maybe in the aging network versus what the disability network is. How we view Let me go to the next slide. how we view specific terms such as care. Care, many in the aging network might feel fine to us in the aging network, but many of these people in the disability community might view that as almost as a dependent term. So just be very mindful of the terminology that you use, how we define self-direction, consumer direction, case management, how we view the medical community. Very different. So just something to keep in mind. I'll recognize that there's differences in staff and organizational capacity, whether it's service regions, and the history of the network. One network may have more of an advocacy base. One network may have more planning and program development. So just something to keep in mind. Be open-minded, transparent, and inclusive as possible. I kind of mentioned that before. And really recognize that there are some cultural differences between some of these networks and organizations that develop. One of the things I did promise before, every single product that has been developed in the ADRC initiative, so every MOU, every issue brief that we've done on partnerships, lead contacts, if you're trying to find who's the lead individual in contact with the ADRC, we have put on the ADRC website, or if you just go to Google and type in ADRC, it should be the first or second item to come up. But it's definitely an excellent resource that you can reach out to. And with that, I think that is my last slide. It is. And I'll turn it back over to you.
Thank you so much, Joseph. That was really, I learned so much that I didn't even know before, so thank you very much. And thank you to all of our panelists. That was really 3 wonderful, very informative, chock full of information presentations. And we may have to come back to each of you and ask you to do a whole webinar individually because there was so much good information there. We are now going to turn this over to Emily, who can tell us if she's been collecting any questions that people have been typing in. And over the next 10 or 15 minutes, we'll try to get through as many of those questions as we can. So if our presenters are willing to hang on a little bit longer, we'll proceed with the questions. Emily?
I have a few that were submitted. The first one I have is a question for Delaware. And this attendee says that you mentioned that you had an advisory committee, which seems great, but also informal and variable. We had that also, but we were stumped when it came time to send out letters and take stands on issues. What are your procedures for voting on what goes out from your network?
Honestly, at this point, we are very informal, and we don't vote. We don't vote on things. We don't have bylaws, so we try to reach consensus. We do have subcommittees that are working on issues. For example, when we were trying to develop the policy for financial assistance eligibility, how we would decide that, we actually worked through that process with the advisory committee and came to consensus. And I think I don't know, that may be unrealistic, but that's really what we're trying to do. We really have stayed away from being formal and voting.
Okay. Next question I have is for Illinois. Terry Alexander writes, are you in conversation with Chicago's Safe Families for Children? This program is through faith communities that provides volunteer respite for children for families that are in crisis.
Chicago Faith Families for Children. No, I am not. I don't know if the IRC is, but thank you for that referral, and we will contact them.
This question's for Joseph. What's the difference between future planning and options counseling?
I actually view them very close, one and the same. I mean, future planning obviously is you are having a negotiation or interaction with an individual about things that haven't occurred, whereas options counseling could also include many times a crisis situation. You're dealing with something that needs to be addressed right away. So I kind of just see that's a slight difference, but I see them very closely related.
And this person writes, I like acknowledging that all the different agencies don't want to lose their identity. How can you support this with all the push to branding?
I assume that's to me, probably, but I can try.
Yeah, it's not. to anybody in particular?
I'll take it since it's come up in ADRCs. I think we could start with, I'll give you an example in Massachusetts. There were 2 organizations there that were in the community for over 25 years each. One was an area agency on aging, one was the Center for Independent Living. They actually had no interaction with each other. Now they have, because of cross-training that they've done, the intake process at each of the organizations is almost identical in terms of what the staff knows and in terms of the forms that they use, yet both organizations have kept their own name and kept their relationship to the community. The actual requirement, not even requirement, an organization changing their name to meet this ADRC, a name is not the priority. It's can we kind of improve both organizations while improving the value that they offer the community. So it can be done. We've seen it done, and we respect it to encourage states or organizations, encourage states to respect local organizations that want to keep their identity.
Okay.
Great question. Good answer.
I have one that's directed to all the speakers today, and they ask, are you able to serve the undocumented? Are there any restrictions on provision of the services to the undocumented?
Can you take that, Barbara, in Illinois?
I'm just thinking, I know that children who are being raised, for instance, by relatives who are undocumented can still get services, okay? But as far as DCFS goes, I would imagine so, but I don't know for sure. If the children were born in Illinois of undocumented parents, then of course they're considered citizens, so I would assume, yes, they are eligible for services.
In a lifespan respite program, for example, it may be representing so many different programs with different eligibility requirements that would be an interesting thing to know about eventually, but it's going to depend entirely on the conditions and the eligibility for each program that's being coordinated.
Also,
how about through the ADRC? If someone walks into the ADRC for information, does it matter if they're documented or undocumented?
Yeah, that's not a question. That would be their primary question they're asking. Their primary goal is developing a relationship with that individual, because their job is probably the first question that person's asking is not the real issue. But I get the sense, though, as they move along in the system, if they move to options counseling or if they really start to move in terms of the access, in terms of public benefits, then it's going to be much harder. But in terms of some of those early stages, I suspect they could get those services quite easily because they would not be asked. With the caregiver services, I would be a respite. It'd be curious who's the customer, or who's the specific individual? Is it the child or the parent, or because some, even in families, you might have some that are documented, some that are not. So who would you go to? It does raise certain issues.
Next question, Emily.
That's all I have submitted at this point.
Oh, okay. If there are any other questions out there, well, you've got 2 seconds to type one in. Joseph, I actually had a question for you, if you don't mind. Can you tell us what percentage of the ADRCs nationally now are serving both the adult and aging population? And is it all categories of disabilities if they are, or just certain disabilities?
We do track that. It actually goes back to the lessons learned. Within the 12 months, anybody who said open their doors to say, hey, we're doing ADRC, within that 12 months, it had to be serving older adults. That was the requirement. And then within the next quarter, they had to have, at least for information and assistance and options counseling, something set up that could reach one additional disability population. So states identified whether it's a physical disability, developmental, intellectual disability. But now what we're seeing a really significant movement towards, and I think is serving all populations. You know, we're trying to reach all because of some of the things that are happening at the federal level in terms of consumer direction, Class Act, really seeing ADRCs, how can we position more to serve more disability groups? But the first question we sent out many times here is just the resources. It's just difficult to keep expanding our database and putting resources from all these other disability groups without any additional funds. So it's much more difficult when those additional resources aren't there. But when they do come, ADRCs are very aggressive at expanding their disability population. So we can get that for you if you'd like.
I think it would be very helpful. You know, there's some concern, I think, among the lifespan respite states that their ADRC may only be serving the aging population. But I think what the Lifespan program brings to the ADRC is, well, here's at least one issue, respite, we can take, you know, we can help you with where you can serve all ages. It doesn't mean just because you're only serving the aging on a variety of other issues that you can't help serve all populations just for this single respite issue, and that's where the respite organizations bring their expertise and develop a great partnership.
Oh, I would agree. And also, if they're actually required, they have to be serving at least one additional disability population. So if you do come across ADRC that, because we had examples where states would say, you know what, I want to be an ADRC, but just for older adults. And we say that's you have that right. You can do that, but you can't be really recognized as an ADRC. So we've had situations where regions or local parts of the country say, well, we want to apply for your next grant, and they're not really, the state really isn't recognizing them because they're not serving the younger people with disabilities. So if they are an ADRC not serving disabilities, yeah, I would check their card just to make sure they really are an ADRC.
Right. Did any other questions come in, Emily?
Nope.
Okay. Well, thank you all very much for, do any of the other presenters maybe have questions for each other before we hang up? Well, then I want to thank all of you again so very much for taking the time to present today, and thank you to all our listeners for participating and asking the questions. And again, you will be receiving a follow-up email from us if you attended today or if you're on the registration list that asks you to fill out a very short evaluation. If you wouldn't mind doing that for us, it's online. It takes about 2 seconds, and you should get information about that tomorrow, as well as how to access the archived webinar, which will be available on the Arch Respite website within the next day or two. So thank you all again very, very much, and we will let you know when our next webinar will be. Thanks again.